I did everything I could to look it up. Then I asked AI, I went and talked to a colleague. I got some information here just so you know that I'm not like I did actually research. And if you read through this, and you can if you want to, I think it's pretty dumb. Basically, it says nobody knows, right? And they use a lot of words. They use a whole lot of words that contradict each other, and they're like sensitivity, ability to correct true positives. It has very few false negatives, and I'm like, those are the opposites, right? And so then I was like, well, tell me. I asked AI, teach me about spin versus spout, and really it felt like contradictory stuff. So I was like, you know what? I'm just gonna let Major Brown be correct, not be she is, right? Like whatever she said is good, and there will not be a correct answer on the test that is sensitivity or specificity. Are we good with that one? All right, I'm not, like I said, sometimes I'm an idiot, but I'm not dumb, and even one of my colleagues was like, yeah, I don't really think anybody kind of knows. We just kind of keep saying the same thing in circles, trying to sound smart. And I was like, that's fair. All right, but then I do have a really important question for you.
Joker.
Joker.
So here's what I love about these icebreaker type of stuff. You can interpret it however you want to. I personally think Dr. Blowhole is the most villainous out of all of these. Probably because my kids grew up watching Penguins of Madagascar. I think that is an incredibly clever, well-written TV show spin-off of the Madagascar movies. Phenomenal show. You guys see at the bottom, you see the lady with the knife. Y'all see Misery? Yeah. Oh man, I didn't sleep for days after watching Misery.
I don't know.
So Thanos was the most correct, somebody said? Somebody said Thanos wasn't a villain. Have y'all seen the Avenger movies? The Marvel comic? So I know that I'm old, and maybe you guys haven't seen them all because you're young and wonderful and have never felt pain. But so my boys and I, we love watching the Marvel comic movies. We love them a ton, right? And so we realized that ever since the mid-90s, they've been putting out these movies. And then somebody went and reordered them, not in a release date, but in like chronological date. They call it the machete order. And it's phenomenal. So you actually can watch them in order of what like the first one was, which is Captain America in the Civil War, right? And so you start there, and then it theoretically, chronologically takes you through all the way to, was it Endgame? Was that the last one? Infinity Wars. Endgame. Yeah. And then after the Endgame, those old heads like me, we said, nope, that's the end of it. You guys can do whatever spin-offs you want. The kids can enjoy it, and we call it Endgame. Okay. So we were in Alaska watching the Endgame, and like, I don't know if y'all seen it or not, but like, I'm just bawling, crying, right? I'm like, why did Spider-Man die? Like, there's no need for it. And so my wife was like, she looks up, she's like, why are you crying? Then she looks down, she's like, why are all the guys crying? And I'm like, don't worry about it. Okay, more important question, is Heath Ledger the best Joker?
Yes.
No.
He's a really good Joker. He did a really good job. Next question, any villains should be on this list that's not on this list? I don't know that name. What is that one?
Harry Potter.
Oh, I've never seen Harry Potter. My kids have. I don't have the energy. So somebody told me that Harry Potter was just Star Wars. And they were like, yeah, an orphan gets taken in by their uncle, goes to a school, learns the ways of magic, creates some friends, and then goes and defeats evil. And I was like, I don't know if that sounds like Star Wars. Is that Harry Potter's line?
Yeah.
Storyline? Quasar? Somebody said no.
Groot.
Jesse Pinkman.
Dwight. I don't know, dog.
George Costanza.
My wife loves Seinfeld. I don't understand Jerry Seinfeld's version of Thomas. I love Gronk. So here's the real question. Top left, you see Han Solo and Chewbacca. For those of you who don't know, that's the best set of movies ever made. The question is who's the sidekick? They're both the sidekicks? I don't know. If I had to die for one, I'd choose Chewie over Han. Chewie's great. We love Chewbacca in our house. Han shot first. All right. Appreciate the interaction. Good to get the communication channels flowing. All right. I like to do, so they used to kind of call them checks on learning. I don't know what the right word to do, just some practice stuff here, so I'll let you read it. Any opposed?
What does the neutrophils have to do with CD4? Yeah, where's CD4?
All right, somebody said, where's the CD4 count, etc. And true or false, HIV is an immunodeficiency state. Would you agree with that?
Yes.
Correct. Please remember when we were talking about the 4 classifications of fever of unknown origin, we have 2. One is immune deficient and one is HIV related. So they're both immune deficient patients, so what has to be present for us to call it HIV related? We have to know the HIV status, and they have to be HIV positive. So, in this situation, and this is a skill set that is not always the most comfortable to become comfortable with, in medical test taking, we have to be comfortable with this idea of there's multiple options there that I feel are justifiable, or I would be thinking about if I was in clinic, right? But given the information that we have, there is a best or most correct answer out of the options that we have. So it's our job when we've taken these tests to develop the skill of A through E with the information I have or that I can synthesize out of which of these options is the most correct. So in this case, do we have the patient's HIV status? No. So can we confidently throw a flag on HIV-related immune deficiency?
Yeah.
Can we confidently say that that's HIV-related fever of unknown origin? That's my question.
No.
We can't because we don't have the HIV status. That'd be an inappropriate test question and answer for me to give you if I don't give you the information that you need to answer the question. So in this case, yes, it has to be on a differential. It's very reasonable to evaluate for it, but given the information that we have, delta is actually a more correct option, and this is kind of what we pull out of the slides. So immune deficient or neutropenic, somebody with failing neutrophil count, which is what kind of pops up to help fight off the infection, inflammation, whatever, is just simply, so it's a little bit more generic than HIV specifically related stuff. And then obviously gives us in our lecture a specific neutrophil count that we're going to look at to call it immune deficient related fever of unknown origin. guess I should have gone all caps with E-L-I-S-A, shouldn't I? That's not a person's name. All right, any thoughts? Echo? Any opposed to echo? Okay, so the skill that's employed here, again, is what we call synthesizing material. Does the test question give you exactly what the condition that the patient has? It doesn't, right? This is what they call a second order test question. In other words, you need to have the confidence and ability to tease out what is going on, and then from that knowledge, answer the question that's at play. So it can be very uncomfortable working through this because now you have to be confident in your assessment of what's actually going on. So let's talk about that first. What does this patient actually have going on? Potentially serotonin syndrome. We got a fever, and contextually, let's say fever of unknown origin, right? Does this fall into classic, immune-related, HIV-related, hospital-associated, nosocomial? Which of those four categories would this most appropriately fall into, given our current state? Classic, yeah, it's classic. And we know that drugs can cause fevers. There are some drugs that come with syndromes or a known condition for fevers. Phenytoin is actually one of them, and so the vignette tells us that this person's on a serotonergic as well as phenytoin, two medications that are classically known to cause potentially some elevated temperatures, right? So in this case, we have to be confident that we have a fever of unknown origin. If you're comfortable enough teasing out that this patient likely meets criteria for serotonin syndrome, also completely appropriate. So from there, notice it doesn't say what are you going to do or what you have to do. Of these options, what is the most appropriate thing to do for this patient? We got to start a workup on this patient. And so we're not just going to go through broad spectrum antibiotics. Is there anything here that screams HIV to you? No, not really. Does the travel history throw it off at all? Not a ton because it was there before the travel history, correct? And so, yeah, I think we don't need to go through all of those. Here's kind of where it comes from. Management, initial management. Stop all the medicines, especially if there have been adjustments or additions to medicines that match up with the timing. Usually that's a pretty good indicator of a player there. Anyone want to take a stab at it? Somebody said Charlie. Any opposed to Charlie? All right, going back to our definitions, we know that somebody with HIV is just more susceptible to opportunistic infections. If they have the ability to fight off the infection with their own immune system, it likely is going to take a bigger hit and take longer to do so. So, classic fever of unknown origin needs how many weeks of fever? You guys remember? Starts with a TH and ends in a re. 3. Perfect. We increase that standard with an HIV patient just because we know their immune system's going to be harder at work. So we need to have at least 4 weeks of an undiagnosed, unclear fever with an a known HIV positive patient. So in this case, the most correct answer there would be Bravo. Notice this is documented, so we know that we have fevers, right? For 5 weeks, and the person has not been hospitalized. So at this point, we've got something kind of more insidious at play, nefarious at play. So we can go work it up. So let's talk about, I kind of like to do this too, sometimes when I'm doing some of these practice questions. Would alpha fall under fever of unknown origin regardless? No, why not? The temperature. It doesn't meet the criteria of 100.9, so we can rule out alpha. Charlie, Why does this not meet classification for HIV-related fever of unknown origin?
2 weeks.
The length of the fever, right? Does Charlie meet the criteria for any fever of unknown origin? It's got 2 weeks and it needs to be how long? 3 weeks. All right, Delta. We have a documented fever, but for how long? 1 day. The implication is in the hospital still, and how long do they need to be in the hospital for before we call it fever of unknown origin? 3 days, right? So in this case, there is post-surgical fevers, and there's even a timeline that's associated with what day they have a fever after surgery that makes it most likely to be whatever. So in this case, they would actually, given only 1 day of fever, go down the post-surgical fever reasoning and ask themselves what meets the criteria for that 0 to 2 days, 0 to 1 days time frame, and look for that. And then echo, does that meet the criteria for fever of unknown origin?
Yes, but not for HIV.
But does it meet the criteria for HIV-related fever of unknown origin? Exactly. So when you guys are reading through these test questions, some of that attention to detail with what's being asked of you will go a long way. This is something that I like to do when I take my tests, and just with time, I kind of figured knowing the material is good, but if I can just be comfortable with my own test-taking skills, kind of broadly speaking, I can put myself in a little bit better areas of success for the test. What's the question that's being asked in this question? Like what, somebody just tell me what the last line says, right? If you read that last line, do you need any part of the vignette?
Not really.
You don't, not really, right? It's wrong as a medical test to not give you some type of background because that's what you're going to see for a test. So I want you guys seeing these vignettes, thinking about them. But what I like to do when I'm taking tests is I go straight to the last line of the vignette and I ask myself, what is actually being asked of me? Sometimes we don't even need to go back and put a lot of work into reading the vignette and teasing stuff out because it becomes a very relatively first order answerable question. I also just simply like knowing what I'm going to be asked, right? So if the question says, what is this patient's most likely condition? Boom, now I know I'm going to be asked a diagnosis question. I'll go and I'll read my vignette through this concept of I've got to tease out signs and symptoms, objective findings, to figure out what's being diagnosed. If it says what's the most appropriate management for this condition, now I've got to figure out what the condition is, at least most likely, what are my treatment options, and then now what does that match up with my answer options at the bottom. So I actually practice that skill taking technique, and so I like to do that. You do not have to do it my way, but if you guys have never played with the idea of just reading the question first, might be something worth chewing on to add into your own skill set to give you a little bit more control over that test. I will say this though, that's just a piece of advice, you don't have to take it. I always read the question first because I want to put myself in as much control as possible. I want to go take the test. I don't want the test to take me. I want to go take the test and knock it out of the park. I still go and read the vignette. I don't ever skip the vignette just because I trust what's going on there. I still read the question, and then once I understand kind of what I'm being asked, I go and I actually read through, tease out, make sure it all makes sense, and then I'll go and answer the question. Again, you don't have to do it my way, but I have found that to be a really, really useful tool when I am reading through these test questions. Any questions about that stuff? Helpful? Not helpful? We're gonna do it anyway, so. If you don't like it, you don't like it. All right, biological warfare. We're going to talk about a couple of things, specifically anthrax, anthrax plague, smallpox, and monkeypox. Those are going to be the items of discussion today. Definition of biological warfare is the intentional, purposeful use of something alive, virus, bacteria, fungi, toxin. I guess toxin may not be alive. It can be alive. And that is used maliciously to produce death or disease in animals, humans, and plants. Here's a screenshot out of the CDC, category A, B, C. We're going to focus on category A because they're the most dangerous. Category A, these have high priority, very easily transmitted. Lots of danger can be happened with these category A weapons. You look at the bottom, second to last main bullet in the symbol, it says lead to widespread fear and societal disturbances. My time in the medical field, there have been a handful of outbreaks of stuff that have just simply caused a lot of concern, right? And I mean, in 2020, we lived through the beginning of the COVID pandemic. We had a lot of unknown features of what was going to happen, what to do, etc. And it was a challenge to sometimes stay kind of calm in that feeling of chaos because of all of the unknown going on. And that was a worldwide situation. I was stationed in Louisiana when there was a little Ebola outbreak in Dallas, and even our little clinic was really worried about people going to Dallas to party for the weekends, catching something and bringing it back, infecting stuff locally. And so not only the actual destruction that some of these weapons can cause, but the fear that ensues with them that can create some diversion and some distraction is at play as well. All right. I'm not going to ask you any questions over the costs, but one of the reasons that biological weapons become so tempting, not only because of the destruction that they can cause, they can be relatively inexpensive to produce and transmit. When I was a student, my microbiology instructor, one of them, said everything is a 24-hour flight away. Every medical condition, every disease, every virus, obviously contagion is what he's talking about. Somebody gets on a flight from some place they were visiting that contracted it, they may not even know that they're bringing it back to wherever they're bringing it back to. And so I was like, yeah, thanks for that, Mr. Man. Appreciate that thought. All right, we're going to start with anthrax. The offending organism, Bacillus anthracis. The method of transmission. If you look at the fourth, it says spores down there, the fourth sub-bullet there, spores. You're going to hear a lot when it talks about spores when it comes to anthrax. And really, the issue isn't whether it's a spore or something else, it's how it gets in contact with the individual. There's a cutaneous form, that's direct contact, an ingested form, and an inhalation form. Here are some case studies. You can read through these if you want. In 2001, anybody in the military during 9/11, 2001, the actual event? I wasn't. I hadn't joined yet. I was old enough to be aware of it. And I remember 9/11, the event happened. There was this like fear, concern, travel changes, all of that stuff, right? But somewhere in the haze of all of that, they were like, and somebody just sent anthrax in letters. And I was like, okay, so we got biological stuff on top of it. And again, added a lot of fear to the moment when there was a lot of unknown. All right, 3 types of anthrax that we're going to review: cutaneous, inhalation, and intestinal. Cutaneous is the most common. It is the most controllable, but it is the most common. Inhalation and intestinal are real bad. All right, cutaneous. If you ever hear somebody talk about a malignant pustule, they're referring to this situation here. Some type of breakage in the skin is present, and they are exposed to an anthrax spore. The classic case is some type of animal that had it on their hide. Now the individual is working with it. They got it on their hide. Hunters, land workers, veterinarians, ranchers, those typically tend to be tied to situations when it comes to cutaneous anthrax. Starts off as a painless, small raised bump. Then they end up with an erythematous papule turned pustule. It vesiculates, and then there ends up being this outer ring of what they call brawny edema. And then there's a black eschar in the middle. And so locally, the skin is trying to do its job, defend this to get from getting into the system. But that brawny edema, and it's really sharply demarcated. If you kind of look at the picture, it's very easy to tell where normal skin hits affected skin, right? It's this big, thick, red, firm, edematous skin, and it's pretty clearly demarcated. And in the middle of it, where the actual papule or pustule, it can create this vesiculated lesion that, as it goes through its maturation process, has this black eschar around it, and then it's recoverable. 25% mortality rate if it's untreated. Black eschar, I kind of started talking about differential diagnosis last time. Anything pop onto your thought process as far as a potential differential if somebody shows up with a black eschar in the middle of their skin somewhere? You guys ever heard of brown recluse bites having a black eschar in the middle? And it's talking about that very, very dark, firm spot right in the middle of it. What's that? Electrical burn? Sure. Picture of somebody with cutaneous anthrax on their face. This individual has it on their eyelid. All right, going over to the inhalation part, we're going to talk about the cutaneous inhalation and ingestion, and then we'll talk about some of the treatments for it. All right, there is a prodromal phase to this. Kind of they feel sick, and then it can get disseminated. This is the inhalation part into their lungs. If you look at that prodromal phase, it looks like an upper respiratory tract infection. Runny nose, sore throat, cough, maybe have some chest pain or not. What does that sound like? Every single virus ever created, right? And so kind of just the point there is to say, hey, there's a lot of these infectious diseases will have a lot of overlapping symptoms. And so as we kind of learn these, obviously it's important to know that, but if we can start to kind of tease out, all right, what are some unique things, identifying pieces of these conditions, it can help us start to tease out what is more likely than others. Then if we go over to the pneumonic phase of this inhalation anthrax, people have a high fever, difficulty breathing, chest pain, and then some bluish discoloration of skin or cyanosis. And a lot of that is because within the pulmonary system, the exchange of oxygen is just not as available because of the infection that's happening, and so they'll get some cyanosis. High mortality rate. All right, intestinal anthrax, also real bad. Nausea, vomiting, diarrhea, fevers, cramps, dehydration. That acute abdomen, they're talking about that patient who is in a ton of abdominal pain. There could be a lot of distension, could be some ascites and some tympany as well. Very sick appearing individual. Here's some testing options that we can do. There's a PCR, an ELISA, nasal swabs, gram stains, cultures, and a high index of suspicion can go a long way, especially if there's some type of career path that puts them a little bit more risk for exposure, or if there's any type of recent known exposure attack. On the bottom right there, you'll see it says gram-positive, and that's talking about the gram stain. Gram-positive spore forming. As you take tests, especially the pants, they love to throw in what the gram stain is included on there, so not the worst idea to remember anthrax is a gram-positive stain. Then a lot of times, if it gets real bad, you can get what they call a widened mediastinum. And the mediastinum is this pocket of space between the lungs and then between the backbone and the breastbone, right? It has a lot of what we call potential space. It means there's not opening in there, but the organs and the structures are just kind of like sitting in there, touching each other. They can be moved out of the way. So as this pathogen does its job, creates a lot of damage and edema, a lot of fluid, in this case blood, starts to leak out of the arteries and vessels into this potential space, and it starts to widen that mediastinum. And so you're going to potentially get this really bright white, wide mediastinum on x-ray, and that's from all the blood that is just pooling into the mediastinal cavity. My heartburn's bad enough as it is. I can't even imagine the heart trying to pump, just covered with edematous fluid and blood. Okay, we're talking about the treatment here. Cutaneous anthrax, just pick one of these two medicines. Cipro or Doxy are great medicines. For this, remember, cutaneous anthrax, pretty recoverable if they're treated. It shouldn't be in the intestinal system, so you should be able to have patients who tolerate oral medications pretty well. Supportive care, we're talking about inhalation and intestinal. A lot of times, especially when I'm talking to my junior ClinCore groups, I get this appreciation that there's not this great recognition or understanding of what supportive care is or means. Feels like there should be these 3 or 4 things that we always do for supportive care. So let's talk about that for a minute. Supportive therapy is a way that we articulate doing stuff that lets the body help heal itself. We're supporting the body's own natural healing process. So supportive therapy, if you have somebody with a self-limiting viral gastroenteritis, what might be some examples of supportive therapy we can offer? Rehydration, rest, maybe some nausea medicine. Are we killing the virus that's in the person's GI tract? We're not. We know that it's going to work its way out. We're helping the body support its own recovery process. Let's say we have somebody with a sprained ankle. It's not fractured, it's just a sprained, swollen ankle. What are some examples of supportive therapy we can do for that individual? RICE, rest, ice, compression, elevation, anti-inflammatory, maybe getting with physical therapy. We are supporting the body's natural recovery process. And so when you hear the word supportive therapy, it's not one preset set of things that we're going to do. It's the things that we know as clinicians that we can offer to help the body's own natural recovery process. So supportive therapy is critical. Inhalation and intestinal anthrax requires 3 antibiotics, and we're going to treat them intravenously for 2 weeks or until the patient is clinically stable, whichever is longer. So it's a minimum of 2 weeks, can go longer. Clinically stable is a clinical decision made by you, us, the treatment team, right? Vital signs are stable, they're mentating appropriately. In this case, intestinal or inhalation, what would be a really important status for the patient to be at before we took them off of IV antibiotics? And I hate this game. The game is called Guess What I'm Thinking Right Now. I absolutely hate it. Sorry to play with you guys, but just putting some stuff into process. We have somebody whose GI and pulmonary, or one or the other, is grossly infected, right? Potentially a bleeding mediastinum or a really inflamed GI tract. What part of patient stability needs to be present before we take them off of IV antibiotics? Swallowing status. Can they swallow pills, swallow water, stuff like that. Obviously that's not the only thing, but that's a great clinical picture that you can evaluate on top of vital signs, mentating properly, etc. It's okay to start some of the anthrax antitoxin. That word, raxibacumab. Anytime you see MAB at the end of a medication, what's it stand for? Monoclonal antibodies. So it's a biologic. There's also some anthrax immune globulin that can be offered. Once that patient is stabilized, the treatment team makes the call, this patient is now stable, and they switch over to an oral antibiotic. You can give that single oral antibiotic for at least 60 days. We're trying to not only continue the killing of the bacteria that's in them, but also promote a lot of healing and hopefully prevent some type of relapse scenario. We can also concurrently begin the vaccination for during that post-exposure prophylaxis period. All right, here is that 3 drug, so supportive care, we talked about that. Inhalation or intestinal. Did you have your hand up, sir?
I did, but my question's right.
Cool. Cipro, meropenem, and minocycline are the 3 antibiotics we recommend using. And of course, you can still see that raxibacumab, the Raxilin, and the immune globulin. Cipro and doxy are the oral antibiotics we can switch to after they are stabilized. And of course, there is again a post-exposure prophylaxis vaccine that we can offer. We talked about this a little bit already. I'll let you read through that. Raxibacumab monoclonal antibody. The anthrax immune globulin is a blood-derived product to try to help fight off the infection, and the vaccine. Underneath the anthrax vaccine absorbed vaccine, 3rd sub-bullet down says does not contain live bacteria. It's an inactivated vaccine. Did we talk about inactivated vaccines any other lectures so far? All right, let's start the paradigm. Fever of unknown origin. No, I'm sorry, HIV, human immunodeficiency virus. At what point does HIV transfer over to AIDS? A couple of different things. CD4 count below, or HIV plus not just an opportunistic infection, an AIDS-defining illness. And there's a preset list of what an AIDS-defining illness is. And we actually had an example there of different CD4 counts that are most common to find some of those AIDS-defining illnesses at. So if you have somebody that has HIV and they have pneumocystis jirovecii, you can go ahead and say, okay, this person is transferred from just an HIV-positive individual to having AIDS, acquired immunodeficiency syndrome. CD4 count below 200. What do we need to remember about their vaccine? No live vaccines. If their CD4 count is below 200, their immune system may not be able to tolerate a live vaccine, so you want to give them an inactive vaccine. Okay, some differentials here. I will never ask you a question that says, on slide 31, what are the 3 differentials for this? This is giving you an example of a lot of these diseases come with overlapping symptoms, and the whole point of a differential is for us to be thinking about some different things that can be going on. Those thoughts in terms of differential should drive our questioning, should drive our exam and our testing to help us pare it down to what is the most likely thing going on for this individual. So, cutaneous anthrax and a spider bite. Let's play with that a little bit. Let's say somebody, a rancher, shows up and like, hey, I got this big old rash on my arm. It's super weird. Why is it so black in the middle? And yeah, it kind of hurts and I've had a fever. Our differential should immediately include, based on his career and the physical appearance, anthrax. Does that career path and appearance of the black eschar also say potential spider bite? Sure does. So there's a famous saying that one of my preceptors told me, famous in my head, sorry, there's a whole crew of people up there. The eyes cannot see what the brain's not looking for. So at that point you can say, cool, have you skinned any animals recently? Any dead cattle around that you may have gotten in contact with? Do you have any broken skin previously? You can also ask, hey, any spider bites that you're aware of, etc. A lot of that can kind of like help us tease out some information that can help us with our differential. Sometimes I feel like we get to a place, I'll fix it. We get to a place where we're like, I shouldn't say we. Sometimes when I'm working with some of my junior clinical students, they'll be like, I figured it out. The person has this, and they're right. They're always right. They're like, okay, what was your differential? Oh, I guess it could have been these 3 things. That's the wrong place for the differential. The differential starts early, and it helps us think about what could be going on, so it drives what we ask and what we do to help us kind of start to pare down to what's most likely going on with our individual. All right, inhalation and intestinal. Obviously, anything that affects the pulmonary system, pneumonia, influenza, or the intestinal stuff, if they have some type of gastroenteritis or diphtheria, could present with a lot of the similar people to that. Plague, the offending organism is Yersinia pestis. The transmission is from fleas, and this is a zoonotic disease. In other words, it's transmitted to humans from animals. Distribution, this can happen anywhere in the U.S. It happens a lot in the desert southwest-ish area. It's not always has to be there, but that's where we tend to get a lot of our cases from. And then you see the bottom 2 bullets there. Fleas are often the vector for the bubonic plague, and aerosolized organisms are the vector for the pneumonic form. There are 3 types of plagues, just like anthrax had 3 types of things. 3 types of plague that we're going to talk about. The bubonic plague, septicemic, aka Black Death. I'm sorry, but if your nickname is Black Death, it's probably a pretty bad one. And then the pneumonic plague. The bubonic plague comes buboes. We'll talk about those here in a second. And the septicemic or Black Death, basically all just so fast, parts of the body start to die from gangrene. And so that's where a lot of that blackness / Black Death comes from. You guys can read this if you want some cases, information about some cases that have happened. A lot on the western half of the U.S., and you can see a large cluster of cases right there in that Four Corners area. I grew up in the desert Southwest. It's a beautiful part of the country. But really classic stories is about people going camping, hunting, living in rural areas, etc., hiking, all kinds of stuff in that Four Corners area, New Mexico, Arizona, Colorado, and Nevada, and then coming back with some type of disease. And then part of the history of that disease is they were bitten by a flea or something like that. And I don't know what's happening in Chicago. They could. I don't know why they choose Chicago and not Atlanta or Orlando or San Antonio, but Chicago's got some fleas in it or something. I don't know. That is Chicago, right? I'm not super familiar with the Midwest. I think that's Chicago. I'm super familiar with the 90s Chicago Bulls. So if anybody wants to talk about the golden era of the NBA, come and find me. Worldwide, it's everywhere. Let's stop for our break there. We'll start at 11 o'clock, 14 minutes. That's hilarious.
Coach said he was gone. Coach said he was gone. Ask me those are the commercial. That's one.
There's a lot of it.
Oh.
Post it up, skin it off, put it on the wall. It's fake. Oh yeah. I told my wife. Well, we shaved each other. He grabbed a razor and I grabbed a razor. Was it?
Take a picture.
My wife actually likes mine.
I know you never met her.
And I told her I'm She said, I'm asking a lot less than he does. No, I'm gonna do spry chicken. Spring chicken.
Somebody take a poll.
Put a poll out. 46 to 30. 31 to 35, 36. Blink of an eye. 5:30 on Friday. A lot of driving. 7 hours. 6.5 hours. I'm on visit in November. Their dues won't be come up until graduation. August. Yeah. Played golf on Saturday, so you guys were outside much on office. Trying to think what was Saturday night. That's it. Because I didn't see anybody. You went shooting on Friday. I saw you at some point on Friday.
I think it was.
Huh? Yeah. Show me a picture of it. Yeah. Saturday was chilly, it was windy. We got there golfing. And I was like, this reminds me of Oklahoma. And it's like 30 mile an hour winds. It's like not
What do they say? Perception is reality.
if you like, she tells me to hit your front of your phone. Oh, like, are you I can't shake it. Shake it harder. You can taste it. We were not that, we were much more direct than that. We weren't that creative. It was always, you know, hands bigger than your face. You have cancer, and you just, like, they hit them with, like, they put salt and ketchup, it makes it warmer. Yeah. No, it doesn't.
Yeah, and you pull back and
That was the oldest. That was my. Right.
That was really hard.
I started reading the questions. I was like,
I knew it'd be hard just on how he talked. So chill. Like, I mean, it wasn't hard. I feel like the hard test was good after 80. He didn't give us what we expected.
Basically, good luck.
Same thing like that. Like, oh, it's gonna be easy.
I have been reading the book, like, the book, like, literally,
Yeah, I saw it.
copy it,
Same shit, so I'm just
same
like,
shit, so I don't understand, like, what chapters am I supposed to be reading that are extra, something.
He made us believe that it was gonna be like, okay, X-ray taking scans on truth. It wasn't the opposite.
there's a lot of weird order questions that you had to know the same size to get
I don't feel like Friday would be. I feel like Friday would be easier than this one. It could definitely be hard. But there's stuff he's gonna have to say. He's gonna have to tell you where it is on the spine. Sprain his brain stuff.
send a picture of that. Change board. No, trust, but just trust.
No, there's enough protein in this.
My brain gets like it's familiar with how we like how you elevate the presence.
I don't like
I have to fight coffee.
I knew his treatments.
I literally said it. I was like, I feel like it's almost up to the student semester trying to be like, what causes it? Like, what are the tests on that? Yep. This one is differential and three. Dude, the high yield sample test. What was it? 3.3. I got one locked in at Citibank where it's 5.2. And then I have the Capital One, and that's why I switched.
Any questions from what we covered so far?
I think this was also.
I don't want to say super straightforward, right? That seems a little bit oversimplified, but graspable. So whenever I was learning this stuff, and to be fair, I still have to relearn it a lot. Have you guys? Do you know SOAP stands for when you're documenting medically? SOAP, right? S is O A P. Perfect, right? What you will recognize with time is that in the medical community, we talk in a SOAP note format. It's just how it always does. In the military, if you guys, just give me an Air Force thing, or maybe a firefighter thing, I don't know. SBAR, have you guys ever heard that acronym? Situation, background, assessment, recommendation. This is SOAP note. It's the same thing, right? We talk in that type of way. So as you move forward and you start having these communication with other doctors, PAs, specialists, lab, radiologists, patients, whatever, you'll start to recognize reflexively, you say, patient says this, which is S, is subjective. I saw this, which is objective. I could see, feel, touch it, or whatever. I think it's this, assessment. I want to do this, or do you have recommendation on this? So we talk in a SOAP note format. When I was learning these originally, I recognized that, and I was like, man, if I could learn these in a SOAP note format, I should be able to be pretty comfortable taking the test on them and seeing the patients, right? So let's talk about cutaneous anthrax. S or subjective. What might the patient tell us? What might they present with? Flu-like symptoms. I got this big rash on my arm. Don't really know what it is. I work with cattle, hunt deer. I was skinning dead animals, disposing bodies, whatever the case is. Right? Subjective. The beautiful thing about subjective is there's no right or wrong to it. They can say whatever they want. It's subjective. That's the patient's report. So objective. So if I've got cutaneous anthrax, what are some objective things I might tease out? The physical exam, right? I might see that malignant pustule, that black eschar. I might see that big, red, beefy, brawny edema that's really demarcated. I might have some fevers. I might have some chills. Maybe I do some labs that send me back some information that point to signs of inflammation or infection. Or we do a gram stain and we get that gram-positive rods or whatever the case is, right? The thing that really kind of set me up for really good success is a hard word to say, really manageable path in medicine is when I recognize A in SOAP stands for assessment, not diagnosis. Sometimes we don't have the diagnosis when we're done working with our patient in that moment, but we can always give an assessment, right? Assessment could be fevers, it could be nausea, it could be belly pain, it could be a headache. We may not have the diagnosis or the etiology as to why they're having their situation, but we can always make an assessment on the patient. Sometimes the diagnosis is the assessment, like if we get our lab data back and we can go ahead and confidently diagnose cutaneous anthrax, now our assessment is also the diagnosis. But recognize plan is not treatment. Plan is what are you going to do to help this patient's life get better, right? That plan may not have any treatment in it at all. It could just be about more workup that you're going to do to help further evaluate, try to figure out what's going on with that patient. The plan could have a treatment in there. That treatment could be pharmacological, non-pharmacological, it could be educational, it could be a follow-up, but plan is this kind of encompassing part of that SOAP note communication that talks about what you're going to go do for that patient. That is not testable per ID, but what I'm getting at is if you are starting to kind of work on these different infectious etiologies, perhaps kind of making yourself a little bit of a thought process there. What are they going to say? What am I going to see? What is my assessment? And what is my plan? It might help kind of overall help you start to digest some of that material. All right. Any sports fans?
Oh, yeah.
No?
Oh, yeah.
Any baseball fans? Nausea, differential, Yankees fans. I've watched baseball my entire life. I adore the sport. I thought that the World Series this year was phenomenal. So I was going to ask you guys what you thought, but if you guys didn't watch it. What's that? Say again? I am not a Dodgers fan. I am a Rangers fan. Yes, I know. Sad, crying.
You got your one.
What's that?
You got your one.
We got our one. We're on the board. It took us 3 tries, but we got one. And that World Series was relatively anticlimactic, other than you're a Rangers fan and you like it. But this year's playoffs and World Series was phenomenal. Any football fans? Anybody watch football this weekend? Yeah. I will say that the NFL playoffs this year have been some of the most exciting playoffs ever. Because I'm a Cowboys fan and we don't ever get to cheer for our own team. It's not just to sit back and watch other teams have at it. I think the secret to success is not letting the Chiefs or the Eagles into the playoffs. As long as they are not in the playoffs, we stand a good chance. Any Chiefs, Eagles fans? All right.
Dilly.
I thought the national championship game was pretty good last night as well. You're like, get to teaching, Mr. Teacher Man. We're not here to talk about sports. We can talk about food if you want. I like food a lot.
Yeah.
I love food. All right, we're in the middle of plague. Talking about plague. There are 3 types of plagues we're going to talk about. Bubonic, Black Death. What was the other one? And pneumonic. All right, bubonic plague is very common. It's the most common. I shouldn't say very common. It is the most common of the Yersinia infections. And you can see, look at those symptoms there. Malaise, fever, headache, fatigue, cough. What does that sound like? Lots of different things, right? And so again, that differential, we start to have a lot of differentials on there, ask certain things. And then people with the bubonic plague will end up with what they call buboes. I do not know the history of that word, why they call it that. But basically, it is an absolutely gargantuan lymph node. It is this huge, firm lymph node. This bacteria tends to invade the immune system, and so usually there will be a lymph node in the general area of where the individual was bitten by the flea at that swells up as part of its reaction to try to fight it. And so you'll get these buboes, massive, huge, firm, indurated masses. And a lot of times with bubonic plague, they'll be in the inguinal canal, the inguinal chain, because a lot of times those flea bites happen on the lower extremities. They're out doing something outdoors and get exposed to that flea bite. Septicemic plague, septicemia, also known as Black Death. There are no buboes present. In this situation, the bacteria bypassed the lymphatic system and went straight into the blood, and it created a absolutely massive destruction, a lot of sepsis, and a situation called disseminated intravascular coagulation or coagulopathy happens, and it takes all of. Have you guys talked about DIC yet? You guys have had clin lab, hematology, pathology, any of it that you might have seen DIC for? A little bit. So the blood has a lot of clotting factors in it, right? There's intrinsic, extrinsic pathway. Any one of those steps gets messed up. We could kick off a blood clot or prevent it from clotting, etc., right? And there's platelets and there's complement, all kinds of stuff, fibrin, all that kind of stuff. Disseminated intravascular coagulation sounds like it should have this like hypercoagulable state, but in a very, very basic of terms, it uses up all the clotting factors, throws a whole bunch of clots everywhere, and then people become easy to bleed. Really easy to bleed because there's not a lot of clotting factors left in the blood. So what we end up is with all these clots and these situations of this vasculopathy and all the bleeding, tissue becomes hypoperfused. And so that's where the gangrenous tissue comes in from, and then AKA Black Death, my guess is when this was a much more uncontrolled scenario, body parts would start to turn gangrenous, dark green, black in color, and the vibe of the whole thing was pretty dark, as well as the physical appearance of it. Anytime you have these small blood clots, they got to get stuck somewhere, and so a lot of times, especially with DIC, you'll get these blood clots in the peripheral vasculature because that's the smallest arteries. And so it's stuff at the end of the arterial flow that becomes gangrenous. Hence, in this situation, you'll get a lot of gangrene of the extremities. And then pneumonic plague, again, no buboes are present. Smaller incubation period, high fever, chills, headache, tachycardia, chest pain, cough, and hemoptysis. We're getting a lot of bleeding in the pulmonic system, and that bleeding leaks out of the cells where it's supposed to be at and into the actual airways, and so people start to cough up blood as well. A couple of pictures to kind of get a visual representation of what this might look like. Okay, see that massive lymph node on the back of the neck there? Yeah, bubo with big old gigantic. All right, some lab tests that can help us out here. A lot of times we'll have a significantly elevated white blood cell count. They can do what they call a fibrin degradation test. And then as you see kind of that second sub-bullet down there, this coagulopathy leads to activation of the coagulation cascade, which leads to a lot of clot formations, and then fibrinolysis happens after that. LFT is being elevated. It doesn't tell us what's being attacked or what is attacking it. We can just tell that the liver is being attacked. And then on the gram stain, it's a gram-negative coccobacillus. It looked like it. See on the right-hand side, they call it safety pin staining. If you actually look at the microscopic picture there, you can kind of appreciate that bipolar appearance, or in other words, the gram-negative staining. Looks like there's this gap in the middle. Looks like a safety pin. And so if you ever get the reading back on a gram stain, this is gram-negative coccobacillus with safety pin staining, that could be a sign of Yersinia pestis. The culture is definitive. And you can also do an ELISA, a DIF, or a PCR. All right. For bubonic plague, 2 medicines that you can use, doxy or cipro. For septicemic or pneumonic plague, recognize it's a stronger antibiotic. Streptomycin or gentamicin. Then if you have somebody who has potentially been exposed to it or is known exposed to it, and you want to offer them some post-exposure prophylaxis, doxy or cipro are good options for that. This list of differentials, again, I'm not going to say, hey, what's on your list of differentials for this, but this gives you an idea of initially when we're working up these individuals, evaluating these individuals, there's a lot of overlapping symptoms and findings and history components that can cause a muddied picture. So we start to ask questions and do evaluations to kind of bring it a little bit more into light. Talk about smallpox and monkeypox, and then I'll be at the end of the lecture. So the first two, Bacillus anthracis and Yersinia pestis, were the causative agents. In this case, we have a virus, a variola virus, causes smallpox. These are airborne respiratory droplets. It's a human-specific disease. It's not a zoonotic disease. And of course, unvaccinated close contacts, those individuals a little bit more at risk because once it starts, it's pretty easy to spread, especially in droplet associated. And then immunity can happen to it either from a natural immunity or a vaccine. Currently no natural sources. It gives you a history piece there. It was originally used or initially used by the British. And then several decades ago, the smallpox vaccination was discontinued, but it was given to a lot of people for a long time. There are two types of smallpox. You can see that on the bottom of the slide there, variola major and variola minor. Underneath the variola major, there are a couple of severe variants, the hemorrhagic type and the malignant type. There's a little bit longer of an incubation period. And look at the prodrome, fever, headache, backache, extreme malaise. What does that sound like? I guess it's probably not truly everything, but a lot of these viruses, it's that immune response. A lot of muscle aches, a lot of fever, a lot of fatigue happens with a lot of these initial responses to being exposed to these pathogens. Then after the prodrome is when the actual rash speaks, or the lesions start to show up. And then right there, the bottom bullet, all are at the same stage of development on a given body part. And so there are some pox-related cutaneous manifestations that they will show up, and they'll show up at different times. So you'll have a body area, say the face, with a bunch of pox on it, but they'll be at different stages of development. Some beginning, some more at the end. Smallpox is one where they tend to show up on a certain body part at the same time, and you should see them basically in the same stage of development. This rash starts usually on the face and the arms, and then it'll spread downward towards the trunk and the legs. And recognize that it does not spare the palms or the soles. There's a lot of cutaneous manifestations to infectious diseases that will not hit the palms or the soles. There are a couple that are. There's another one that's, I don't want to say pretty popular, pretty well known for including the palms and the soles. What's that? That's a great answer. It's wrong because it's not what I was thinking. It's not what I guess what I'm thinking right now. Hand, foot, mouth. Excellent answer. Syphilis. Syphilis is one that tends to include the palms and the soles. And so, whenever we think palms and soles, handful of diseases should pop in here. So, kind of playing with that idea of a differential. Someone says, hey, I got a fever, I've been feeling sick. Okay, cool. You can have any virus, bacterial infection, cancer, autoimmune disease, no demand. Copy, it just hit me real bad. I'm really sick, or really tired, really sore. All right, probably more infectious in nature. I got this rash. Where did it start? Started on my face, arms, neck. Cool. Starting to lower it down. Does it involve the palms of your hands? Sure does. Look, here they are. Now we can start to rule out certain things that don't typically involve palms and soles, and we can start to say, all right, more likely, hand, foot, mouth, syphilis, smallpox, etc. And that's how you can start to utilize that tool of the differential diagnosis to ask questions, to start to rule in and rule out different conditions. All right, smallpox characteristics, the bottom half of the slide there. It starts with a maculopapular lesion. They vesiculate. Then they become round, intense, embedded pustules. Those pustules then crust over and scab. And then with time, because they're so deep-seated and they hit the sebaceous glands, they tend to have some pretty bad scarring associated with it. Kind of an example of some of the progression of these smallpox. Here's kind of some early on. All right, just looking at this picture, see the face and the trunk. Face compared to trunk. Can you start to pick up that trunk is just significantly less involved than the face? And that's what it's talking about when I described. It's a little bit, hits more the face and the arms, and then with time it'll move towards the body, but it tends to hit the face and the arms a lot more heavy than the center of the body. And when you look at these lesions, do you see a lot of variation in the stage of the lesion? They all look like they're pretty stable, right? Obviously, there might be a little bit of variance, but you're not going to have you're not going to tend to have a lot of brand new ones mixed in with a lot of old ones. I mean, that all happened in less than a week to this poor kiddo. And In this picture, obviously, this is, you see it's a smallpox recovery in third world, but compare the chest and the belly to the face and the arms. One of them is significantly more impacted than the other. All right, we were talking about the hemorrhagic and the malignant. The hemorrhagic is a kind of a subset, if you will. You're going to have this super dusky erythema. It's just a different response to this specific strain of smallpox. Then you get some petechia, and then you're going to get a lot of hemorrhaging. The skin and the mucous membrane start to bleed. There's no overt pox per se, but it's still from the virus. And then malignant smallpox, longer incubation period. These are softer, flattened, velvety vesicles. And I've never felt one with my hand. I don't know that it truly has that soft, velvety texture, but they like to use the word velvety to describe this condition specifically. Red, fine-grained skin coloration, and then there's no true pustules or scabs with the malignant smallpox. Here's a picture of that hemorrhagic one. Still smallpox, still the same virus, but you can hopefully appreciate that's just not a true pox-like formation. That's much more petechia, which is these little small bleeding spots. That's because of the vasculopathy that's happening secondary to the virus. Here's that malignant smallpox. Got that reddish, softer appearing texture to it, velvety. For the most part, this is diagnosed clinically. We get a history, got a patient population that's a little bit more at risk. We see pox that show up, see what they look like, see their distribution, and we start to narrow down through a lot of that history and physical exam what is most likely happening. So then we get this diagnosis made by clinical presentation. Clinical diagnosis is what they call that. I just see it, and I'm going to evaluate it, and I'm going to call it what it is. A lot of times these labs are used to identify stuff during an epidemic. And smallpox being as virulent as it is, you can see on the bottom half of the slide there, if you have samples, I say you, like, you know, a lot of us aren't going to find ourselves in a situation handling a lot of what I'm talking about, but some knowledge of what happens is probably value added in this scenario. And if you end up on a team that is working on this, then you guys should have some understanding of it. But if you are going to try to sample some of this, send it off in a high containment sample, a vacutainer to a high containment sample, or a lab, excuse me. Obviously, contact the CDC, they can help you out with this. The third bullet down there, tecovirimat and brincidofovir. They both have VIR in them, so what are the most likely type of medicines we got here? Antivirals, and we know we're treating a virus here, so these antivirals can help us with this virus. Will antibiotics help these individuals? No. So they won't necessarily help kill the virus, but if you've got these open pox wounds on these individuals, is there a chance for a secondary bacterial cellulitis to happen? Or infection somewhere else? Absolutely. And so if you do find yourself in a situation where you have a secondary bacterial infection, antibiotics can obviously be helpful with that. And then if you have somebody that's been exposed to it, post-exposure vaccination can be helpful as well. There is some immune globulin available. And again, post-exposure prophylactic antibiotic, not helpful because it's a virus. So a lot of supportive therapy as well. Variola major versus minor, you can see the mortality rate of one over the other is significantly higher in the major. Hemorrhagic, uniformly fatal by day 6 of the rash. I mean, that's just a very quick onset to expiration. And then malignant smallpox is pretty fatal as well. All right, we can see the central or the nidus of the infection. You guys see on the distal part of that redness what looks like an ink drawn line? Any idea why that might be there? Absolutely. So somebody put that on there and said, hey, this is roughly where the border is, and they can track if that secondary skin infection starts to spread that, it might be a sign of it worsening versus it gets farther away from that line, be a sign that it's improving. All right, so smallpox versus chickenpox. Obviously, chickenpox is still around and available. There is some differences. They're both virus related. And this chart here kind of gives you some information about separating the differences so that if you have somebody come in with a pox type of presentation or concern, some history teased out from the patient and or patient's family might be helpful in recognizing what's going on. One of the things that you see on the left, second one down, the prodrome for variola, it says fever 2 to 4 days before it rashes. So there are some situations that you'll hear people talk about. It's a fever that rashes, not a rash that has a fever with it. And so a lot of times if you can tease out that somebody has had a prodrome, they had a fever, and now they've got a rash, you might be dealing with variola a little bit more likely than varicella. And then the POC distribution. The word centrifugal versus centripetal. Centrifuge, are you guys familiar with that tool at all? Heard that word? So centrifuge spins something to make the stuff inside of it go which direction? Towards the middle or towards the outside? Outside. So when they talk about a centrifugal distribution, those POCs are more on the outside extremity part of the body. The head, the arms, the legs. Doesn't mean it can't be on the center, but it's more likely to be centrifuge towards the outside. It's not centrifuge, but centrifugal. Centripetal, or center, means they're more likely to be on what part of the body, or area of the body? The center of the body. And so when we're trying to dissect, does this person have chickenpox or smallpox? If they did not have a fever, all of a sudden they had a rash, they were sick, and they had a fever with it. Most of the smallpox or pox are on the torso, very few on the arms, none on the palms, maybe more likely varicella than variola. If you have somebody with a prodrome that has a fever, then they all of a sudden got these pox show up, and it's mostly on the face, arms, palms. You might be dealing more with a variola picture than not. The evolution of the pox, variola versus varicella, again, synchronous versus asynchronous. In other words, chickenpox or varicella, you're going to have lesions in different stages of development. You can have some that are old, crusted over, ulcerated, and some that are very beginning at the same time, whereas the variola typically the similar age of development. You guys can read the rest of that there. Some pretty cool stuff there to help kind of differentiate the two between each other. Yeah. My apologies for missing it. What you got?
Is it contagious across like all the stages of the rash, or is only specific to certain stages?
Usually it's pretty contagious throughout the course of it. Once it gets into that scabbed over healing stage, less contagious. But a lot of these times they can be pretty contagious. On this slide, you see where it says POC appearance. Under varicella, it says vesiculars on an erythematous base. And then variola just says vesicular to pustular. We're not talking about varicella directly right now, but a lot of times you'll hear people describe the chickenpox lesion as a dewdrop on a rose petal. I think somebody got really fancy with their description many years ago, and it just stuck around. But what they're trying to describe is this area of erythema that only part of it has a vesicle on. So the base erythema on the skin is a little bit bigger than the actual vesicle itself. And so you get this, what they call a dewdrop on a rose petal formation. And then we're talking smallpox versus chickenpox, and we talk about centrifugal versus centripetal. Smallpox on the left, you can see lesions much more prevalent in the distal aspects of the body, whereas chickenpox much more in the central aspects of the body. Here's some differentials that could similarly overlap with presentation. And there's syphilis, number 2, because it hits the palms. All right, monkeypox. Only a couple more slides here, and then we'll be done. The organism is the monkeypox virus, and this is transmitted with close infection or close contact with an infected animal, potentially rodents or monkeys. It can be transmitted human to human. the smallpox vaccine helps a little bit, but it isn't overtly for the monkeypox. Typically in Central and Western Africa, not as severe, but still pretty contagious. And the incubation time frame is a little bit longer. Still gets the palms of the hands. All right, symptomatic care, similar to supportive therapy. We're trying to give these individuals something that'll help them feel better. Fourth, isolation. Obviously, we don't want to spread it. Fourth bullet down there, you can see a couple of antivirals mentioned. Tecovirimat, cidofovir, and brincidofovir. Antibiotics are in play if there's a secondary infection that's bacterial in nature. The vaccine immunity can wane after a little bit. If you do have some post-exposure, a vaccine may help that individual as well. I get it. I know it's a lot, and you're just like, man, these are a lot of words and a lot of things, and it feels very overlapping and confusing. With some review of the material, this does tend to settle. Okay? And I'll do my best to kind of bring in some test questions and some reminders later on so we keep layering this information on for us. You guys are pretty smart, so I don't anticipate a lot of struggles for you guys. Any questions about what we went over today? All right, that was lecture.